Dr. Robert Lelouch, a board-certified OBGYN physician with over 30 years of experience. And today we're going to talk about hormone replacement therapy in menopause, or estrogen replacement therapy. Now, this is a big topic, and I could speak to you for 10 hours and not tell you everything there is to know, but I'm not going to do that, trust me. And I've avoided it for a little bit because there have been a lot of recent transitions in our thoughts on this. But basically, to encapsulate for you, before 2001, when I saw patients, I would tell them when they go through menopause that there's benefit to hormone replacement therapy. It would help prevent aging of the skin, thinning of the hair, thinning of the bones. It might help prevent Alzheimer's, and it probably reduces your risk of heart disease. Now that's the controversial point. Will keep you youthful, will help maintain your sexual function, help prevent vaginal dryness, all of those benefits. And then around that time in 2001, a study came out, the Women's Health Initiative, that was made in order to try to prove that there was a decrease in the risk of heart disease. That's what the reason for the study. And it came out showing the opposite. Complicated. That's when all the scare happened about hormones, and everyone stopped taking it in 2001. And also it showed, and again, the second controversy point, perhaps an increased risk of breast cancer. Okay, so the theory initially was, in general, we know that women get heart disease and heart problems and heart attacks about 10 years later than men, and the theory was that it was estrogen. Okay, so that study kind of blew things out of the water. The company Wyeth went bankrupt. They're the ones who made Premarin. Over the years, reanalyzing the data and reconsidering it, they have realized a few things. And now, recently, the black box warnings about the heart attack and heart disease risks and breast cancer have been lifted by the FDA. Okay, so what happened? Well, in order to try to prove a benefit in reducing the risk of heart disease, they selected older patients who already had heart disease in their 60s and 70s. So if you already haven't been on hormones for many years and you're in your 60s and 70s and already have high cholesterol, hardening of the arteries, coronary artery disease, cardiovascular disease, then estrogen replacement therapy, especially orally, can increase your risk of blood clots, and that can increase your risk of heart disease and strokes. Not a good situation. On the other hand, what we've discovered over long years of looking at the data is if when you don't already have the vessel disease and you're younger, just going through menopause in your 50s, that it does appear to delay it. And there's the benefit, okay? Also, the increased risk of breast cancer was not statistically significant. What that means is it was just a trend, but didn't prove anything. And by the way, that same study with women who did not have a uterus are only on estrogen alone, so you need progesterone if you have a uterus. So if you don't have a uterus, estrogen alone, it showed a decrease in the risk of breast cancer. So basically, we're not telling you it reduces it or it increases it. What we do know is if you have breast cancer and your cancer has estrogen receptors, then taking estrogen will definitely make it worse, especially initially. Although if you watch my vaginal estrogen video, you can see that even that doesn't happen in the tiny amounts for vaginal estrogen. But systemic estrogen, meaning pills through the skin, gel, that level to get for hot flashes, mood swings, vaginal dryness, osteoporosis, all of those benefits, you wouldn't get that if you had estrogen receptor positive breast cancer. Okay, so those are the benefits that you can get from it. Now, the data initially was on oral, but there's lots of more information supporting the transdermal through the skin. So instead of pills, I recommend through the skin. If you take it through the skin, it goes through your skin into your bloodstream. If you take a pill, it goes into your stomach, through your liver, then into your bloodstream. So it's more physiologic, like the ovaries used to give if it goes through the skin. And when it goes through the liver, that alters the binding globulins in the liver and affects the coagulation things, which is more likely to increase the risk of blood clots and perhaps stroke. So that's why I like to avoid it as a pill, although the studies were done with a pill, number one, and number two, the pill's cheaper. But the prices are coming down, so that's what I generally encourage you to get. So bottom line is, if you're just going through menopause, you're having symptoms, you're having mood swings, poor sleep, hot flashes, then the old adage of the smallest amount possible for the least time possible, or not at all, stay away from hormones, is gone, and you can relax a little bit, but you need to talk to your provider. Tailor your treatment. Do you have high blood pressure? Are you a smoker? Do you have other risk factors? Do you have family histories? Do you have other reasons why it's not appropriate for you? So discuss it with your provider. Make sure that they are up to date on the latest information, because things have evolved. But in general, I think you may benefit quite a bit by getting estrogen replacement therapy when you're just going through menopause or in your younger 50s, and probably on later, as long as you started earlier. If, on the other hand, you're seeing this for the first time, you haven't been on hormones, you're 75, you're a smoker, I wouldn't recommend it at all, or already have heart disease. And but again, talk to your provider to tailor your information. This is just to spark your interest and know that there is new evolution in therapies, new information, and that it's warranted to discuss it with your provider. One last thing, the newest area, or the hot area, is testosterone. I'm not bringing that up here. There's a lot of evolution with that, a lot of different waves on the internet, and not as much data as we like, not as much information, but they're doing research, it's evolving. So I'm holding off on that for now, but I would start out with the estrogen if you have no uterus, or estrogen and progesterone therapy. I hope you found this of use. Please leave your comments. Thank you.